फिर से लाइव आ चुके हैं गाइस। हेलो आसिन यासिन जियासी, हेलो भाई, प्लीज़ सब्सक्राइब माई चैनल। यदि सेशन को ज्वाइन कर रहे हो तो लाइक भी करो। 2 लोग ज्वाइन कर चुके हैं। मैसेज इन द चैट बॉक्स। थैंक यू यासिन जी आरसी भाई, चैनल को सब्सक्राइब भी कर दीजिए। यासिन जी आरसी जी चैनल को सब्सक्राइब भी कर दो भाई। हेलो हेलो,
based on the etiology associated lipocalin. Okay, right. So this is NGAL. Third marker is called KIN. What is that? Kidney injury molecule 1. So these are the newer biomarkers for assessing the renal function. Okay, right. Now let us look at the causes of acute kidney injury. It is of three groups actually: pre-renal, renal, and post-renal. Based on the etiology. Okay, pre-renal means a condition where there is a decreased perfusion to the kidney. Okay, so due to some NGAL. Third, the second one is AI groups actually: pre-renal kidney injury molecule 1. So these are the newer biomarkers for assessing the renal function. Okay, right. Now let us look at the causes of acute kidney injury. It is of three groups actually: pre-renal, renal, and post-renal. Based on the etiology. Okay, pre-renal means a condition where there is a decreased perfusion to the kidney. Okay, so due to some reason the blood supply or the perfusion to the kidney is affected, we call it pre-renal. And what are the conditions under this pre-renal causes? It would be any condition where there is a fluid or blood loss from the body. It can be due to a dehydration, or it can be due to a shock, due to possibly blood loss following a trauma. All these things can be coming under decreased perfusion. Or it could be due to a congestive cardiac failure, wherein the blood supply to the different organ is affected and kidney blood supply is also getting affected. Or it could be due to a congestive cardiac failure, wherein the blood supply to the different organ is affected and kidney blood supply is also getting affected. Or it could be a problem in third space loss, which occurs in cases of sepsis and in conditions like nephrotic syndrome, where there would be a third space loss. So all these will decrease the effective circulating blood volume, because of which the blood supply to the kidney gets affected, and that is called as a pre-renal cause. Then coming to the renal cause is a problem inside the kidney itself. Okay, it can be due to ATN. What is that? Acute tubular necrosis. Acute tubular necrosis. And one of the important reasons for acute tubular necrosis itself is decreased perfusion. Okay, so decreased perfusion to the kidney can manifest as acute tubular necrosis. Very important. It is basically ischemia of the tubules resulting in necrosis. That is what's called ATM. The second category under this renal cause would be conditions of glomerulonephritis. Okay, glomerulonephritis. Like acute glomerulonephritis can be associated with decrease in the renal function as well. Okay, that can be a renal cause. And third important renal cause would be HUS. What is that? Hemolytic uremic syndrome. Very important. Hemolytic uremic syndrome. I will discuss about hemolytic uremic syndrome shortly in this module itself. Okay, right. Little later I am going to discuss that. Then the third category would be post-renal. That means outside the kidney. It is usually due to obstructive causes. It is usually due to obstruction. And that obstructions would be due to what problems? It could be due to tumors causing an obstruction, or it could be due to stones in the urinary tract which can cause an obstruction, or it could be conditions of obstructive uropathy. I was discussing some time back, anomalies causing obstructive uropathy. What are they? Yes, PUJ obstruction, pelvic urinary junction obstruction, or it could be due to PUV. What is that? Posterior urethral valve. All these are post-renal causes. Okay, right. These are the different category of conditions which can cause acute kidney injury in children. Okay. Now, usually the most common cause is pre-renal category. Very important. The most common category is pre-renal. Don't forget this. So due to a problem of decreased perfusion only, the kidney function is getting affected. Okay. Now coming to management of acute kidney injury. Remember, there are only two parts of management. One is identifying the cause and treating it. For example, if it's a dehydration, okay, fluid correction, all those things have to be done. Next thing would be management of complication. These are the two things in the management. Okay. First, we will start with the fluid management in case of acute kidney injury. Okay. And this fluid repletion, that means replacing the fluid, is recommended for what type of AKI? It is nothing but pre-renal AKI only. Okay, right? In pre-renal AKI only, there's a decreased effective circulating blood volume. So you have to give fluids in this particular situation. How much of fluid to be given? It is around 20 to 30 ml per kg of NS. What is that? Normal saline should be given over 45 to 60 minutes. This is the initial fluid repletion if it is a pre-renal AKI. Now you have to assess the response after this. How do you assess the response? After giving fluid, if the kidney starts functioning, what is the feature you will see? Yes, there will be urine output, okay? And at least how much of urine output will tell you that there is a response, okay? At least 2 ml per kg of urine output is noted. Then we can say that there is a response to fluid therapy in this particular check. Okay, right. Suppose even after giving fluid therapy also, oliguria is still persistent. That means the kidney are not starting to function. Then what you can give is, you can give a diuretic. And in the setting of renal failure, what is the only diuretic that will work? Very good. It is furosemide is the diuretic which will work. Usually given the dose of 1 to 1.5 milligram per kilogram. This is a fluid management in case of pre-renal acute kidney injury. Then moving on to renal causes. Renal AKI. See, in renal AKI, it is not fluid repletion. It is
हाय आदित्य सिंह, हेलो, फाइनल ईयर में हूँ। आप भी मेडिकल स्टूडेंट हो क्या? हेलो आदित्य सिंह।
fluid restriction. Very important. Why? Because the kidney is not functioning. So already there is edema inside the body. So it is important that you should give fluid restriction in case of renal acute renal AKI. See, in renal AKI, it is not fluid repletion. It is fluid restriction. Very important. Why? Because the kidney is not functioning. So already there is edema inside the body. So it is important that you should give fluid restriction in case of renal acute kidney injury. So how much should be the fluid? I will calculate according to the insensible water loss, which is 300 to 400 ml, 400 ml per meter square. This is nothing but the insensible water loss. Along with that, I have to take into account the urine output also. Okay, so I will combine these two values, and that would be the daily fluid which I'm going to give for a child with renal causes of acute kidney injury. Okay, so that's about the fluid management in case of acute kidney injury. Then I told you management of complications should be done. One is about the anemia. Generally, remember in the setting of AKA, anemia is not in case of acute kidney injury. Then the daily fluid which I'm going to give, along with that, insensible water loss, which is 300 to 400 ml injury. So how much should be the fluid? I will calculate according to the insensible water loss, which is 300 to 400 ml, 400 ml per meter square. This is nothing but the insensible water loss. Along with that, I have to take into account the urine output also. Okay, so I will combine these two values, and that would be the daily fluid which I'm going to give for a child with renal causes of acute kidney injury. Okay, so that's about the fluid management in case of acute kidney injury. Then I told you management of complication should be done. One is about the anemia. Generally remember, in the setting of AKA, anemia is not an actual complication because it occurs due to hemodilution. Very important, hemodilution. Okay, so that is why once you do the fluid management and you restore the fluid status, anemia tends to get spontaneously corrected. So most cases you don't need to treat it. However, if it was a blood loss condition, think about this. Patient had a road traffic accident to get hemodilution. Very important, hemodilution. Okay, so that is why once you do the fluid management and you restore the fluid status, anemia tends to get spontaneously corrected. So most cases you don't need to treat it. However, if it was a blood loss condition, think about this. Patient had a road traffic accident because of which so much of blood loss, and that itself could have precipitated acute kidney injury. For that patient, you have to give transfusion. What transfusion you are going to give? PRBC transfusion. What is that? Packed red blood cell transfusion is what is recommended here. This is what you have to remember. Okay. So this is about the management of anemia. Generally not required, but if it is an identifiable cause like a blood loss, you have to go for transfusion. Then children with acute kidney injury can have metabolic acidosis, for which what should be given?
हाँ भाई, देख रहा हूँ जेई एडवांस्ड। क्या नाम है भाई तुम्हारा, बताओ।
Hyponatremia also tends to get corrected. So no need for separately managing a dilutional hyponatremia. However, if the patient is having severe hyponatremia and he is having seizures, that means it is a symptomatic hyponatremia, then you have to give 3% of saline. Or what do you call the saline? Hypertonic saline. Correct. You call this as hypertonic saline. Only if the patient is symptomatic, you give hypertonic saline.
हाँ भाई, मेंस हो गया, कितना परसेंटाइल था?
Otherwise, no need for any particular treatment. Then, one more problem which is encountered in electrolyte imbalance that is important for exams also is hyperkalemia. Hyperkalemia. And by definition, hyperkalemia refers to a serum potassium of more than how much? 5.5 milliequivalents per liter. And this has to be managed.
वाह, बहुत अच्छा, कंग्रेचुलेशंस भाई। एनआईटी तो अभी मिल ही गया होगा, एडवांस के लिए प्रिपेयर करो। बेस्ट ऑफ लक, ऑल द बेस्ट। एडवांस कब से होने वाला है वैसे?
Very correctly. In hyperkalemia management, there are two things which you have to make a note of. One is, of course, decreasing the potassium only. Another very, very important point to be noted is myocardial stabilization, because very high levels of potassium, especially more than 7 milliequivalents per liter, are associated with arrhythmia problems or conduction abnormalities and can be associated with cardiac arrest also. So that is why very high levels of are only. Another very, very important point to be noted is myocardial stabilization, because very high levels of potassium, especially more than 7 milliequivalents per liter, are associated with arrhythmia problems or conduction abnormalities and can be associated with cardiac arrest also. So that is why very high levels of serum potassium, you should also take care of myocardial stabilizations as well. First, let us look at the first part. What is that? Decreasing the potassium. How do you decrease the potassium? It is by different measures. One is you can give insulin glucose drip to decrease the potassium, insulin glucose drip. Any other way? Yes, sodium bicarbonate. Any other thing? You can give nebulizations with a salbutamol. You all know about this. All of these treatments, what are they going to do? They are going to push the potassium into the cell. They will shift the potassium intracellularly, thereby the level will decrease in the blood. That is how they are going to act. Is there any other group of medication which can decrease the potassium by promoting the excretion of potassium? Yes, it is the potassium binders can be given, which will promote the excretion of the potassium. And for this purpose, what you can give is potassium binding resins can be given, or we can also use KX which is nothing but sodium polystyrene sulfate. Okay, right. So you can decrease the potassium by either pushing it into the cell or by causing excretion of potassium. Then, very, very important is the next part. What is it? Myocardial stabilization. It is typically achieved by giving a slow IV infusion of 10% calcium gluconate. Very important point. And the key word here is IV infusion, and one more is it should be given very slowly, because if you give a rapid push of IV calcium, that itself can cause conduction abnormalities in the heart and can have dangerous consequences. So it's always when you give calcium gluconate infusion, you should do a continuous cardiac monitoring as well. That is also important. So these are the ways by which hyperkalemia is managed. Suppose I have a situation of hyperkalemia and I tried every possibilities, okay, every possible treatment, and still it is not controlled. Then we call it as refractory hyperkalemia. And for refractory hyperkalemia, there is no other treatment other than taking up the patient for dialysis. This is what you have to remember. Okay, so that's about the management of complications in acute kidney injury. So in essence, management of AKA is treating the cause, fluid correction, as well as management of complications. So that is about the discussion of acute kidney injury in children. Next, I am going to discuss about hemolytic uremic syndrome, or HUS, which is one of the conditions coming under the category of renal causes of acute kidney injury. Now we are going to see some salient points about him. It is treating the cause, fluid correction, as well as management of complications. So that is about the discussion of acute kidney injury in children. Next, I am going to discuss about hemolytic uremic syndrome, or HUS, which is one of the conditions coming under the category of renal causes of acute kidney injury. Now we are going to see some salient points about this condition. It is basically a condition of hemolysis and kidney damage. That is what is written as uremia. Okay, right. It is a two types actually based on the etiology.
जो भी सेशन को ज्वाइन कर रहे हैं प्लीज़ लाइक करें, और यदि आप नए हैं तो प्लीज़ सब्सक्राइब करें। मोस्टली तो नए ही होंगे क्योंकि ज़्यादा सब्सक्राइबर्स है नहीं इसमें। 3 लोग अभी देख रहे हैं जिसमें कि 2 लाइक हैं। जो नहीं किए हैं कृपया कर दें भाई। एक्यूट किडनी इंजरी AKI पहले एक्यूट renal failure कहा जाता था। एक्यूट इम्पेयरमेंट ऑफ द फंक्शन का डेफिनेशन उसका सीरम क्रिएटिनिन बढ़ जाता है। इसको 2 चीज़ से असेस करेंगे, सीरम क्रिएटिनिन और यूरिन का। और सीरम क्रिएटिनिन 2 चीज़ देखी हैं, उससे नेगेटिव वैल्यू तो सीरम वैल्यू 3 मिलीग्राम पर डी से भी ज़्यादा होगा 48 घंटा तक। और रिलेटिव इंक्रीज में और 7 डिस्ट्रिक्ट नॉर्कोटिक भी घट जाता है, डिक्रीज हो जाता है, जिनको 60 के स्टेज 1 2 और 3 स्टेज स्टेज 3 में 3 कोर्स बढ़ जाएगा। सेंसस डायलिसिस और उसका इफेक्ट एस्टिमेटेड डिपेंडेंट होता है, डिलेड राइज होता है, डिलेड राइज होता है। उसका ये होगा अनरेगुलर होगा। क्यों? क्योंकि ये जो है प्रीवियस बेस एब्सेंस ऑफ प्रीवियस बेस और बेस प्रीवियस बेस वैल्यू का एब्सेंस होने की वजह से। जाहिर उद्दीन चौधरी, हाँ पढ़ाई कर रहे हैं। हाँ पढ़ाई कर रहे हैं भाई, पढ़ाई कर रहे हैं। विस्प्रीत कौर, विच ईयर? फाइनल ईयर हूँ। भाई उधर ध्यान नहीं गया था, जो भी मैसेज किया है फिर से करो, मैं रिप्लाई करूँगा। जीवन साथी डॉन, ये भी आप किस चीज़ का तैयारी कर रहे हो भाई? जीवन साथी मेडिकल स्टूडेंट हूँ मैं, फाइनल ईयर मेडिकल स्टूडेंट, MBBS। CNBL past, regional past, local or posterior past, regional past, not a posterior, never past, regional perfusion decrease perfusion, decrease third space loss. Space or space loss. Nephrotic syndrome. हेलो हिजनवर्ड भाई, इससे पहले भी आप ज्वाइन किए थे, वेलकम अगेन। हेलो हेलो वैभव शर्मा, हेलो। यूपीएससी वैलिडेशन मेरा पढ़ाई की नहीं भाई, ऐसा बात नहीं है। वैलिडेशन नहीं ले रहा हूँ। सच्चाई ये है कि अपना वॉच टाइम या फिर सब्सक्राइबर कंप्लीट करना चाहता हूँ। ये कॉमन सी बात है भाई, सच्चाई है। पढ़ाई का वैलिडेशन लेने का क्या ही मतलब, कोई मतलब थोड़ी है।
How are you going to define this? First, will be based on the renal function. What is that? Glomerular filtration rate. It will be a decline in the glomerular filtration rate, and by definition, it is less than 60 ml with hemolytic uremic syndrome. Next is about the condition of chronic decline in the renal function or
वुमेन्स राइट के ऊपर 2 लाइन कह दो, क्या कहना है भाई, क्या सुनना चाहते हो तुम?
chronic kidney disease. How are you going to define this? First, will be based on the renal function. What is that? Glomerular filtration rate. It will be a decline in the glomerular filtration rate, and by definition, it is less than 60 ml per minute per 1.73 meter square. And renal function or chronic kidney disease. How are you going to define this? First, will be based on the renal function. What is that? Glomerular filtration rate. It will be a decline in the glomerular filtration rate, and by definition, it is less than 60 ml per minute per 1.73 meter square, which is nothing but.
इसलिए तो हरियाणा का एकदम सेक्स रेशियो काफ़ी कम है भाई, ये गलत बात है। बिहार भाई, फिर तो तुम्हारा गेमिंग सेटअप कंस्ट्रक्शन साइट होगा। क्या मतलब भाई? मैं गेम खेलता ही नहीं हूँ।
The body surface area. And if the decline in the renal function is more than or equal to 3 months, then only it comes under the criteria for chronic kidney disease. So this number is something which is very important, 3 months. Okay. So one in terms of GFR we can do that. Other in terms of persistent renal abnormalities, which is also persisting for more than or equal to 3 months, then also it is called as chronic kidney disease. What is this persistent renal abnormalities? It could either be a structural abnormality, like for example, there is an anomaly which is persisting for more than or equal to 3 months, then we can call it as chronic kidney disease. Or it could be a persistent lab abnormality related to the kidney. For example, persistent proteinuria or persistent hematuria, which is there for more than 3 months, then also we can call it as chronic kidney disease. Next is about staging of chronic kidney disease. This is again based on glomerular filtration rate. There are actually 5 stages which are described. Okay. In first stage, actually the glomerular filtration rate is more than 90. This is something like a increased glomerular filtration rate, right? So this is called as hyperfiltration stage. Hyperfiltration stage. Let us understand why there should be hyperfiltration in the initial stage. It's a simple concept only. What is that? We are expecting a decline in the GFR, but here I am saying there is an increase in the GFR. Why? Because in the early stages, few areas of the kidney would have been already affected. Okay, and as a compensation for this, the surviving nephrons will undergo hypertrophy and will try to increase the kidney function or
भाई मैं नीट वाला हूँ कि जी मेंस में इतना परसेंटाइल आई है और मैं नीट भी क्रैक करूँगा एंड जे एडवांस भी। अच्छी बात है भाई, कंग्रेचुलेशंस जेई मेन में इतना लाने के लिए। बाय द वे मेरा भी 90 परसेंटाइल था जेई मेंस में, बट उसका कोई फ़ायदा नहीं है। फ़ायदा मतलब सेल्फ सेटिस्फेक्शन के लिए। अच्छी बात है, क्रैक करो भाई, जाओ कोई एम्स दिल्ली लो या कोई एम्स लो, अच्छी बात है। कंग्रेट्स ब्रो।
bring it back to normalcy. Okay, and as a compensation for this, the surviving nephrons will undergo hypertrophy and will try to increase the kidney function or bring it back to normalcy. So that is why, due to this hypertrophy of the surviving neurons only, there will be increase in the GFR in the early stages of chronic kidney disease. That point should be remembered. But that will be only the initial stages. After that, there will be a progressive decline in the GFR only. In stage 2, what is going to happen? There will be a GFR in the range of 60 to 89. Then stage 3, it will be progressive decline, increase in the GFR in the early stages of chronic kidney disease. That point should be remembered. But that will be only in the initial stages. After that, there will be a progressive decline in the GFR only. In stage 2, what is?
मैं नीट 4 साल पहले दे चुका हूँ भाई, 2021 का मैं पास आउट हूँ नीट। अभी मैं NMCH पटना में हूँ, फाइनल ईयर। ठीक है, न्यूट्रॉन, अपना नाम बताओ भाई क्या है? न्यूट्रॉन तो नहीं होगा आई थिंक।
Going to happen chronic kidney disease, bring it back to normalcy. So that is why, due to this hypertrophy and the GFR, but here I am saying there is an increase in the GFR. Why? Because in the early stages,
मॉक टेस्ट में एनालाइज करने के लिए क्या कर सकते हो? मॉक टेस्ट में एनालाइज करने के लिए एक तो जो बना लियो, एक बार थोरोली देख लो कि कौन कौन सा सही है और तुम कॉन्सेप्ट सही लगाए हो कि नहीं, और जो गलत हो रहा है उसको एक बार उसका कॉन्सेप्ट थोरोली देख लो। उस पर भी ज़्यादा टाइम वेस्ट नहीं करना है, बट उसका थ्योरी जो है एक बार ज़रूर देख लिया करो। एक मिस्टेक कॉपी बनी है, नहीं समझा मैं तुम्हारा बात। वैसे अब इस साल तुम देने वाले हो नीट क्या? ओके, तो अब तो ज़्यादा समय है नहीं, अब ज़्यादा मॉक टेस्ट पे मत फोकस करो। अभी ज़्यादा जो है रिवीजन पे टाइम दो, जितना ज़्यादा तुम चीज़ों को ग्रैस्प कर सकते हो उस चीज़ पे टाइम दो। अच्छा, मिस्टेक कॉपी बनाए हो, हाँ बहुत सही है, उसको रिवाइज करते रहो, मिस्टेक वाला कॉपी जो भी बनाए हो। न्यूट्रॉन भाई चैनल को सब्सक्राइब कर दो ताकि नेक्स्ट टाइम मैं लाइव आऊँ तो तुम्हें नोटिफिकेशन जाए और तुम कुछ मेरे से पूछ सकते हो। अच्छी बात है, यदि तुम्हारा जेई में इतना अच्छा परफॉर्मेंस है तो फिर आई थिंक नीट में भी अच्छा रहना चाहिए। ऑल द बेस्ट उसके लिए, प्रैक्टिस करो, अभी तो है तुम्हारे पास समय है, 7 दिन है, बट अभी मतलब कि 5 दिन ही हुआ। मैं है स्टडी विथ मी, तुम्हारा नाम क्या है भाई? न्यूट्रॉन तुम्हारा नाम क्या है? अपना नाम लिख लो चैट में। लाइक भी करो सेशन को। न्यूट्रॉन स्टडी विथ मी, स्नेहा नाम है। ओके, कहाँ से हो स्नेहा? लाइक करो सेशन को ताकि ये और भी बच्चों को जा सके हमारा सेशन। आपका कौन सा सेशन? मेरा 3rd अटेम्प्ट में हुआ था। मेरा पेरेंट्स बोल रहा है कि मुझे MBBS करने के लिए, बट आई एम थिंकिंग टू गो टू IIT एंड। देखो भाई, तुम्हें जो करने का मन है वो करो, पेरेंट्स के अकॉर्डिंग डिसाइड करना आई थिंक उतना सही नहीं होगा, क्योंकि तुम्हारा मन में कुछ है और तुम करने जा रहे हो कुछ, तो लाइफ टाइम तो रिग्रेट ही फील होगा ना। अब मान लो कि पेरेंट्स के तुम अकॉर्डिंग डिसीजन नहीं लिए, तो ज़्यादा से ज़्यादा तुम्हें 6 मंथ सुनाएंगे, ठीक है, उसके बाद तो तुम खुद, वो लोग भी भूल जाएंगे, तुम भी भूल जाओगे, कोई मतलब नहीं रह जाता यार। तुम्हें जो बेस्ट लग रहा है उस चीज़ को लो, किसी और के कहने पे नहीं, ठीक है। अपना गोल क्लियर रहना चाहिए कि तुम्हारा क्या एम है और तुम क्या करना चाह रहे हो। नहीं, मैं इंटर्नशिप में नहीं हूँ, मैं अभी फाइनल ईयर में हूँ। मेरा भी नेक्स्ट अटेम्प्ट है, इस बार नहीं होगा मेरे पास, में मार्क्स आएगा, मुझे नेक्स्ट ईयर सेलेक्ट होना है। वैसे भी मैं हार्ड वर्किंग हूँ, बट इस बार स्टूडेंट से नहीं हो पाएगा। अभी इतना होप नहीं खोना चाहिए। अभी तुम्हारे पास 5-7 दिन समय है। लास्ट में थोड़ा रिवीजन करते रहो, जितना रिवीजन करोगे उतना सही। अब नहीं होना वो तो टाइम डिसाइड करेगा ना, अभी तुम्हें क्या ही मतलब है होगा कि नहीं होगा, वो समय पे छोड़ दो। अभी तुम पढ़ाई करो, वो इम्पोर्टेंट है। वही तो बोला मैं तुम्हें कि अभी आपको पढ़ने पे फोकस करना चाहिए, थोरो रिवीजन पे। तुम जितना ज़्यादा से ज़्यादा रिवाइज कर सको। अभी मॉक टेस्ट नहीं भी देते हो तो चलेगा, क्योंकि लास्ट टाइम में तुम्हें जितना पढ़ पा रहे हो वही ज़्यादा सही रहेगा। कभी कभी यदि मन करे तो 1-2 दे दिया करो, उतना ज़्यादा ज़रूरी नहीं है। मैंने बहुत चैप्टर नहीं किए। अच्छा, अब जितना किए हो उसको फोकस करो। मान लो इस बार नहीं होता है तो कम से कम उतना मार्क्स तो आए जिससे कि तुम्हें सेल्फ सेटिस्फेक्शन फील हो, और जो तुम्हें मतलब कि जितना आ रहा है उतना यदि लिख पा रहे हो तो अच्छी बात है, नेक्स्ट टाइम में तुम्हें बूस्टअप मिलेगा। बहुत बढ़िया। न्यूट्रॉन तुम्हारा नाम क्या है भाई? तुम क्रैक कर लोगे यदि ऐसा है, ठीक है। उस दिन बस अच्छा रहे, सब अच्छा ही होना चाहिए, ठीक है। अच्छी बात है। नेहा नाम है ना? नेहा नहीं, स्नेहा नाम है, स्टडी विथ मी जो लिखे हुए हो। कौन से बुक? देखो, बुक तो NCERT इनफ है, NCERT सबका, ठीक है। उसके अलावा तुम जो क्लास नोट्स टीचर्स पढ़ाते हैं वो इनफ है, ठीक है। उसको बार बार रिवाइज करते रहो, और जो भी तुम बनाए हो हर साल उसी को बार बार करो, ठीक है। DPP की थी बट मार्क्स इम्प्रूव नहीं हुआ, इस बार तो रिवाइज करूँगी, बट स्कैम ना हो जाए। वहाँ गया। क्या बोल रहे हो न्यूट्रॉन, मुझे नहीं समझ में आ रहा भाई तुम्हारा बात। जितना हो सके रिवाइज करो और क्या। डिमोटिवेशन कैसे दूर करें भैया। डिमोटिवेशन सबको आता है, सब लोग डिमोटिवेट होते हैं। उस समय में अपने आप को बस ये फील कराना है कि तुम कर सकते हो, और ये चीज़ उस टाइम सोचो कि इतना दिन जो हम पढ़े हैं वो किसके लिए पढ़े हैं। अभी यदि डिमोटिवेट हो जाएंगे तो फिर क्या ही मतलब है इतना दिन पढ़ने का। ठीक है, तो उस समय में अपने आप को मेंटली मतलब स्टेबल हो करके रखो खुद को। ठीक है, सोने का मोबाइल कम यूज करो। ठीक है, सोने का प्रॉब्लम तो आजकल सबके साथ है भाई। सोने का प्रॉब्लम मोस्टली सबके साथ है। ठीक है, मोबाइल को दूर रख दो, अपने आप नींद आएगा। स्टार्टिंग में प्रॉब्लम होगा 15-20 मिनट, ठीक है, उसके बाद नींद खुद ही आएगा। दो लोग जो चैट कर रहे हो, दोनों ने सब्सक्राइब और लाइक किया है क्या? यदि हाँ तो एक बार बता दो। 4 लोग अभी वॉच कर रहे हैं, 4 लाइक्स भी हैं। मुझे मोटिवेशन मिलता है यदि कोई मतलब कि लाइक करता है सेशन को। अभी जैसे मैं पढ़ाई कर रहा था, ठीक है, अभी तुम लोग से बात कर रहा हूँ, तो यदि कुछ थैंक यू थैंक यू। एनी अदर क्वेश्चन? स्नेहा एंड न्यूट्रॉन। न्यूट्रॉन, तुम अपना नाम नहीं बताए, क्या तुम्हारा नाम न्यूट्रॉन ही है? मैंने लास्ट मोबाइल यूज़ किया था 5 मंथ्स पहले, देन आज यूट्यूब थोड़ा सा ओपन किया तो आप ले लाए मैं। अरे वाह, तब तो अच्छी बात है, अच्छा कोइंसिडेंस है। अच्छा है, मोबाइल यूज़ करना कभी कभी ज़रूरी पड़ जाता है, इसलिए सही भी है और गलत भी है। उसका ओवर यूटिलाइजेशन बहुत घातक होता है। कौन सा ड्रॉप है ये तुम्हारा? अरे फर्स्ट ड्रॉप ही है तो हमारा खुद 3rd अटेम्प्ट में हुआ है। 3rd 4th 5th तक लोग जाते हैं, तुम्हारा तो फर्स्ट अटेम्प्ट ही है। फर्स्ट अटेम्प्ट में इतना क्यों सोचना? देख लो, बट यदि तुम्हारा मन है नीट के प्रति तो तैयारी कर सकते हो। मैंने तो बीएससी नहीं किया था, मेरा भी मैंने बोला ना 2019 में मेरा 12 था, उसके बाद 19 में भी नहीं हुआ, 20 में भी नहीं हुआ, फिर 21 में हुआ। तो इतना तो ले ही सकते हैं, रिस्क तो लेना ही चाहिए। लेकिन ये है कि यदि तुम इम्प्रूव नहीं कर रहे हो तब थोड़ा प्रॉब्लम होता है। जैसे मेरा था कि फर्स्ट अटेम्प्ट में 405 आया, सेकेंड अटेम्प्ट में जो है मेरा 574 आया, थर्ड में 624 आया। तो इम्प्रूवमेंट हुआ तो मैंने रिस्क लिया। ठीक है, अब खुद में तुम इम्प्रूव नहीं कर रहे हो तो थोड़ा प्रॉब्लम तो होती ही है ना। ओके, गुड गुड न्यूट्रॉन। देखो, ड्रॉप अपने अकॉर्डिंग देखो। ठीक है, यदि तुम कर पाओगे तो ज़रूर ड्रॉप लो। ठीक है, ड्रॉप लेने से जो है फ़ायदा ही होता है, घाटा नहीं होता। हमें खुद जो है जितना टफ फाउंडेशन में लग रहा था उससे जो है आसान काफ़ी लगने लगा था ड्रॉप ईयर में। बहुत अच्छी बात है, मेरा तो 405 ही था फर्स्ट अटेम्प्ट में, बताओ। बहुत सही है न्यूट्रॉन, तुम इस बार 4 के आओ, फिर मेरे लाइव सेशन में तुम जो है इसको बताना तुम्हारा कितना आने वाला है। अरे कोई नहीं, दोस्तों से क्या मतलब है, खुद पे ध्यान दो ना। दोस्त का क्या हो रहा है नहीं हो रहा है उससे कोई मतलब नहीं है। तुम कहाँ हो नहीं हो, अपना सेल्फ एनालिसिस करो। दोस्त कितना क्या कर रहे हैं उससे क्या मतलब है। हमारे भी बहुत सारे दोस्त जो है कहीं और हैं, एक एम्स भोपाल में है, कोई अच्छा पीएमसीएच में है, तो उससे क्या, उससे हमें फर्क थोड़ी ना पड़ेगा। ऐसा बात तो हम नहीं बोल सकते हैं, ठीक है। होप सो कि वो सही बोल रहा हो, किसी की भलाई हो तो अच्छी बात है ना। अरे तो कोई नहीं, उसका सिलेक्शन हो जा रहा है तो अच्छी बात है ना, उसके बाद वो तुम्हें गाइड करेगा, ठीक है। लड़कियां तो और ज़्यादा सेलेक्ट होती हैं मेडिकल कॉलेज में, ठीक है, तो फिर हो जाएगा। नहीं नहीं, यदि अच्छा रिलेशनशिप है तो थोड़ी ना तुम्हें छोड़ेगा। रिलेशनशिप में इस चीज़ का प्रभाव तो नहीं पड़ना चाहिए कि तुम कहाँ हो और कहाँ नहीं हो। हाँ ये भी है भाई, यहाँ पे तुम्हें प्राइस थोड़ी ना देगा। तुम मेरे से यदि झूठ बोल ही दोगे तो तुम्हारा मेरे मतलब कि अंदर क्या इम्प्रेशन नहीं है, क्या ही फ़र्क पड़ता है। मैं जहाँ हूँ यहाँ पर तुमसे कोई मतलब ही नहीं है। बस ये है कि यदि तुम्हें अच्छा आ रहा है तो अच्छा लगता है मुझे। अरे तो कोई बात नहीं है, कभी लाइफ में उतार चढ़ाव आते रहता है, ठीक है। तो इस चीज़ को मैनेज करना चाहिए। और ख़ासकर लड़कियों की ये बात है कि वो पढ़ लेती हैं, और ये अपोजिट केस मैं देख रहा हूँ कि लड़कों का जो है थोड़ा अच्छा हो रहा है, लड़कियों का कम हो रहा है। बट कोई नहीं, लाइफ में ऐसा होते रहता है। यदि नहीं होता है, अब सबसे बड़ी बात इस समय तो तुम्हें सोचना ही नहीं चाहिए कि इस बार तुम्हारा होगा कि नहीं होगा। अभी 5-7 दिन है, जितना हो पा रहा है उस चीज़ में अपना बेस्ट करने का कोशिश करना है ना। डर तो इस समय ऑब्वियसली लगेगा, सबको डर लगता है, डर की तो बात रहती है, तो लेकिन उसी चीज़ को ओवरकम करना है, ठीक है।
Few areas of the kidney would have been already. What is that? We are expecting a decline in the GFR, but here I am saying there is an increase in the GFR. Why? Because in the early stages, few areas of the kidney would have been already affected. Okay, and as a compensation for this, the surviving nephrons will undergo hypertrophy and will try to increase the kidney function or bring it back to normalcy. So that is why, due to this hypertrophy of the surviving neurons only, there will be increase in the GFR in the early stages of chronic kidney disease. That point should be remembered. But that will be only in the initial stages. After that, there will be a progressive decline in the GFR only. In stage 2, what is going to happen? There will be a GFR in the range of 60 to 89. Then stage 3, it will be 30 to 59. Stage 4, it will be 15 to 30. And in stage 5, it is going to be less than 15 ml per minute per meter square of GFR, or the patient would have been already started on dialysis. So this is about the CKD staging based on the GFR. The next is about the etiologies of chronic kidney disease. See, any chronic problem in the kidney can lead on to chronic kidney disease. Okay, and these etiologies based on the GFR. The next is about the etiologies of chronic kidney disease. See, any chronic problem in the kidney can lead on to chronic kidney disease. Okay, and these etiologies could be multiple. I'm just trying to group them under few categories. Okay, one would be like obstructive uropathy, for example, conditions of stones, tumors, or something like strictures causing a chronic obstruction to the kidney function. See, on dialysis. So this is about the CKD staging based on the GFR. The next is about the etiologies of chronic kidney disease. See, any chronic problem in the kidney can lead on to chronic kidney disease. Okay, and these etiologies could be multiple. I'm just trying to group them under few categories. Okay, one would be like obstructive uropathy, for example, conditions of stones, tumors, or something like strictures causing a chronic obstruction to the kidney function. Then it can cause CKD. Or it could be due to reflex nephropathy. Where have you studied reflex nephropathy? Under a condition of PUR, vesico-ureteral reflex, which can cause scars inside the kidney and can predispose to chronic kidney disease. Or it could be conditions of chronic glomerulonephritis. For example, we were talking about IG nephropathy, the Burgess disease, where it can have a chronic glomerulonephritis that can also predispose to chronic kidney disease. And not to forget, all the structural or developmental or the congenital anomalies of the kidney, if they are persisting for a long period of time, they are also going to result in CKD. And out of the different categories I have mentioned for CKD, the most common category associated with CKD is the last one. What is that? Congenital or developmental anomalies is the most common group associated with CKD in children. Okay. Now moving on to the management of chronic kidney disease. Basically, if you have a reversible condition, for example, a structural anomaly which can be corrected, that should be attempted in the management of CKD. If it is going to be a non-reversible condition, then we may start with the medical management. The medical management is basically supportive management, first in the form of diet. Please remember this point. There should not be strict dietary restriction for a child with CKD because our main aim is to promote nutrition and growth of the child. So there should not be strict dietary restriction. And a child with CKD is encouraged to take PUFAs. What is that? Polyunsaturated fatty acids as well as complex carbohydrates, because these substances will positively influence the growth and nutrition of the child. Next is regarding protein restriction. It's a conventional teaching that protein should be restricted in a patient with CKD. That's what we have studied in adults. But in children, protein restriction is not at all recommended, because if you restrict the protein so much, it will adversely affect the growth of the child. So that is why protein restriction is no. Recommended. Next is regarding anemia. Remember, anemia is a common accompaniment in chronic kidney disease, and it is usually encountered when the GFR falls below 30 ml per minute per meter square. This is the time at which anemia is usually manifesting, and the main reason for anemia in CKD is decreased production of a substance from the kidney. I have given you the clue, you tell me the answer. What is the substance when it is produced in decreased quantity from the kidney can result in anemia in the meter square? This is the time at which anemia is usually manifesting, and the main reason for anemia in CKD is decreased production of a substance from the kidney. I have given you the clue, you tell me the answer. What is the substance when it is produced in decreased quantity from the kidney can result in anemia in the setting of CKD? Yes, it is something related to erythropoiesis. What is that? Yes, erythropoietin. Erythropoietin. That is the reason. So that is why when you are managing these children who have CKD and anemia, what should be given in the management? Erythropoietin itself should be given in the management. What we have is a recombinant form of erythropoietin called as, any name for that? Derbipoietin. Yes, usually given as a subcutaneous injection, and that is used for the management of anemia in chronic kidney disease. Next, another important problem is bone disease in a child with CKD, which is what I am naming it as mineral bone disease. First, let us see what is the reason for bone disease. Main problem is decreased levels of active form of vitamin D. What is active form of vitamin D? It is 125 dihydroxy vitamin D. That's what we all have heard about. Okay, and the active form is produced with the help of an enzyme in the kidney. What is that? 1-alpha hydroxylase. In CKD, the problem is decreased production of the enzyme 1-alpha hydroxylase. So thereby, the active form of vitamin D is not produced, and this is going to result in low levels of calcium, hypocalcemia. And because of hypocalcemia, which hormone will be triggered for its release from the gland? What is that hormone? Yes, there will be parathyroid hormone released from the parathyroid gland. This is what we call secondary hyperparathyroidism will occur. Hyperparathyroidism will occur, and that is going to cause bone resorption. This is important. Okay, so this is one set of bone problem occurring in the setting of chronic kidney disease. Second important is that in advanced CKD, what is going to happen is the kidney function will be so much impaired that there will be decreased excretion of phosphate from the kidney. So thereby there will be increased levels in the blood, or hyperphosphatemia will be noted. Hyperphosphatemia will be noted. These are the different set of problems encountered with relation to bone disease in case of CKD. So quickly recollect what are the problems we are encountering. Decreased levels of active form of vitamin D, hypocalcemia, secondary hyperparathyroidism, as well as in advanced CKD you get hyperphosphatemia. So when you're going to manage these children with the bone disease, you have to supplement whatever is deficient as well as try to tackle the other problems as well. So what is the first one? I told you there's decreased levels of active form of vitamin D, so that should be given as a supplementation. What is that? Calcitriol should be used in the management. Calcitriol is nothing but the active form of vitamin D. Second, calcium, of course, which is deficient. Also has to be supplemented in the management. You don't need to take care of hyperparathyroidism because once the calcium level normalizes, the parathyroid levels will normalize as well. Okay, so that is why separately hyperparathyroidism need not be tackled. Third, we have hyperphosphatemia. So how will you tackle that? You have to give something called phosphate binders. Okay, phosphate binders. And these phosphate binders can either be calcium-based phosphate binders, which includes calcium acetate as well as the calcium citrate, or we can use a non-calcium based binder. Can you tell the name? It's an important MCQ question. Non-calcium based phosphate binder. What is that? Yes, it is sivalamer. These are the different medication useful in the management of mineral bone disease in the setting of CKD. Next is about growth management in a child with CKD. We all know that a child with CKD develops short stature, and as a part of management, you can give growth hormone itself. We use RGH. What is that? Recombinant growth hormone. Please remember, setting of chronic kidney disease is one of the established indication for growth hormone treatment, which I have covered under endocrinology modules itself. Okay, right. Then the last part is regarding the hypertension management, which is a part and parcel of any chronic kidney disease. There are different things in the management. First would be the non-pharmacological, which includes salt restriction. Salt restriction, and the guidelines say the restriction of salt should be less than 2 grams per day. Okay, right. And also lifestyle modification like salt restriction, which is a part and parcel of any chronic kidney disease. There are different things in the management. First would be the modules itself. Okay, right. Please remember, setting of chronic kidney disease is one of the established indication for growth hormone treatment, which I have covered under endocrinology modules itself. Okay, right. Then the last part is regarding the hypertension management, which is a part and parcel of any chronic kidney disease. There are different things in the management. First would be the non-pharmacological, which includes salt restriction. Salt restriction, and the guidelines say the restriction of salt should be less than 2 grams per day. Okay, right. And also lifestyle modification like promoting an active lifestyle, thereby keeping the weight within the limits. All these will help in the management of hypertension as a part of non-pharmacological treatment. Next would be the drug treatment or the pharmacological one, and the first line medication would be ACE inhibitors, angiotensin converting enzyme inhibitors. And the second group of medication which would be helpful would be ARBs. What is that? Angiotensin receptor blockers. So these are the drugs useful in the management of hypertension. So these are the different medical management in chronic kidney disease. Okay. However, if the chronic kidney disease becomes progressive and at one stage medical management alone is not sufficient, then we will have to go for kidney replacement therapy. It was previously called renal replacement therapy. Now it is called kidney replacement therapy. What are the options available? You all know how it is done. One is dialysis. Another one is transplantation, renal transplantation. Okay, right. Now, when should you start this kidney replacement therapy? I told you, it's going to be in the late stages where medical management alone is not sufficient. This is what we call ESRD, end stage renal disease. And guidelines say that in the transplant replacement therapy, now it is called kidney replacement therapy. What are the options available? You all know how it is done. One is dialysis. Another one is transplantation, renal transplantation. Okay, right. Now, when should you start this kidney replacement therapy? I told you, it's going to be in the late stages where medical management alone is not sufficient. This is what we call ESRD, end stage renal disease. And guidelines say that when the GFR level falls to less than 12 ml per minute per meter square, that is the time when you have to start this kidney replacement therapy. Now, out of the two options, dialysis and transplantation, which is always the better one, you all know it is only transplantation which is the better option. However, till the time the child is waiting for a donor to be available, we have to perform dialysis, because for transplantation, donor should be available and it should be a matched donor. So till the time the child is waiting out of the two options, dialysis and transplantation, which is always the better one? You all know it is only transplantation which is the better option. However, till the time the child is waiting for a donor to be available, we have to perform dialysis, because for transplantation, donor should be available and it should be a matched donor. So till the time the child is waiting for a donor, you will do dialysis. We all know two options are available in dialysis. One is the peritoneal dialysis, another one is hemodialysis. Now, just some quick points. Out of these two dialysis which can be performed at home, peritoneal dialysis is the convenient one because it can be performed at home setting itself. Second important thing to be noted is it is done around 12 hours per day. That should be the duration of peritoneal dialysis, 12 hours per day. And it is more convenient because it's done in the home setting. Not only that, it also helps in the better control of hypertension. Studies have proven that. Better control of hypertension. These are the main advantages of peritoneal dialysis. Next is about hemodialysis, which is obviously done in the hospital setup and usually done 3 times per week. And each session of hemodialysis will last around 3 to 4 hours. These are the salient points regarding hemodialysis in children. So these are the various options available for kidney replacement therapy, and that is about the management of chronic kidney disease. We have completed the modules on acute and chronic kidney disease in children. Now I am going to provide you a quick summary of the same. First point, most cases of acute kidney injury are due to pre-renal causes. I already told you, pre-renal means it's a condition of decreased perfusion to the kidney, and the main management of acute kidney injury is fluid correction as well as electrolyte imbalances management. So that's about management of acute kidney injury. Next, while talking about AKI, different causes I told you, HUS is also an important cause of AKI and is usually mediated by what? What mediates the manifestations of HUS? It's a toxin mediated. If you can recollect, what is the name of the toxin? Yes, Stigar toxin. Very correct. Yes. Then, management of D plus HUS, which is a common type of HUS, is purely supportive. That is what, okay? And ravulizumab and eculizumab are useful in what type of HUS? It is not D plus HUS, it is D minus HUS. These monoclonal antibodies are going to be useful. Okay, right. Then last one I told you is about CKD, and final management of CKD is always kidney replacement therapy, wherein transplantation is always a better option compared to dialysis. But till the time the child is waiting for a donor to be available, we have to perform dialysis in patients with chronic kidney disease. So that's about the summary points in AKI and CKD. We'll just quickly finish with few MCQs. In Schwartz formula for calculation of eGFR in a child, the following parameters are used except length, creatinine, weight and a constant. What is that? Obvious answer is weight only, because how it is calculated? eGFR is equal to length of the child into constant, that is what I am writing as K, divided by serum creatinine. And quickly recollect, what is the constant number I asked you to remember? It is 0.4, right? Okay, so that is something which you have to know about. So with that question, I am completing the module of acute and chronic kidney disease in children.
Hi Saroj.
What is that? Protein creatinine ratio more than 2 is also significant for proteinuria, or it is a massive proteinuria. So all these are definitions of massive proteinuria, which is the hallmark feature of nephrotic syndrome. In addition to proteinuria, what are the other findings? Very simple. Protein loss will result in decreased protein in the blood, characterized by hypoalbuminemia, which is defined by serum albumin less than simple. It is a massive proteinuria. So all these are definitions of massive proteinuria, which is the hallmark feature of nephrotic syndrome. In addition to proteinuria, what are the other findings? Very simple. Protein loss will result in decreased protein in the blood, characterized by hypoalbuminemia, which is defined by serum albumin less than 3 grams per deciliter. And because of this decreased albumin, there will be decrease in the on-contact pressure also, leading to what problem? Edema will be present, and here it is a generalized edema, also called by what name? NSR. And in this particular condition, there is an increased production of lipoproteins and lipids in the liver, characterized by hyperlipidemia. Okay, so these are the important components of the this particular condition, there is an increased production of lipoproteins and lipids in the liver, characterized by hyperlipidemia. Okay, so these are the important components or definitions of nephrotic syndrome. Now we should know what are the conditions which are associated with nephrotic syndrome. Or in other words, you tell me what is the pathology in nephrotic syndrome. This is a very straightforward question. The most common pathology in children is MCD. Very correct. It is minimal change disease. Minimal change disease. That is the most common pathology in children with nephrotic syndrome. Now, there are also other conditions, other pathologies in nephrotic syndrome, but they are not commonly encountered. So you should know the names alone. What are the other group of lesions called? They are called significant change glomerular lesion, meaning there will be multiple abnormalities noted. And can you tell one best example of this significant glomerular lesion? It goes by the name of FSGS. What is that? Focal segmental glomerulosclerosis. In this group, this is relatively a common condition. Now, there are other conditions also, which include mesangial-proliferative glomerular nephropathy, and one more is CT glomerular nephropathy. Okay, all these are significant change glomerular lesion, but overall, most common is minimal change disease only. That will be the discussion in pediatric nephrotic syndromes. So, few details about this minimal change disease. What is the minimal change we are talking about? It is the loss or effacement of foot process of the podocytes. You all know that podocytes are the glomerular epithelium, which contain ultramicroscopic structures called foot processes. That becomes of foot be the discussion in pediatric nephrotic syndromes. So, few details about this minimal change disease. What is the minimal change we are talking about? It is the loss or effacement of foot process of the podocytes. You all know that podocytes are the glomerular epithelium, which contain ultramicroscopic structures called foot processes. That becomes lost or effaced in case of minimal change disease. What is the problem? Foot process normally have a negative charge. Okay, due to loss of foot process, there is loss of negative charge. And now what is the problem? Very simple. This negative charge of the foot process is acting as a repelling force for the negative charged proteins in the urine. So what is going to happen? Once the glomerular filtration is happening, this foot process will repel away all the proteins from being excreted in the urine. Very simple. However, whenever there is loss of foot process, there is loss of negative charge. So there is no repelling factor for the protein. So the protein will start getting excreted in the urine, or this is the reason for proteinuria. Loss of negative charge is the reason for protein loss in the urine. This is how proteinuria occurs in minimal change disease. Okay, right. Clinical features will be the same. And what is that? You will have a child who is having generalized edema, and on investigation, you will find out significant proteinuria. That's how you establish the diagnosis of minimal change disease. And once you are diagnosed, how are you going to manage these children? Okay, first thing to be noted is the diet management. Remember, there is excessive loss of protein. So the child should be given high protein diet. Very important. High protein diet. Okay. And what about salt? See, salt need not be restricted, but you should not add any excessive salt, because that itself can contribute to further edema. So I'm going to write no added salt. This is very important. No added salt. Okay, right? Normal salt can be taken. Now, if I ask you, what is this drug which will help in the management of a child with nephrotic syndrome due to minimal change disease? What is your answer? It is going to be steroids. Very, very important. A child will show excellent response to steroids. Very important. Excellent response to steroids. And in fact, this is the hallmark feature of nephrotic syndrome due to minimal change disease. You have a child with nephrotic syndrome, and if the child is responding to steroid, your number one diagnosis is minimal change disease. What is the steroid we are going to use and how much? Prednisolone is the steroid, and it is given over a period of 12 weeks. It's a long duration steroid. Yes. How this 12 weeks is given? First 6 weeks, you have to give daily dose of steroid. How much is the dose would be? It is 2 mg per kg per day with a maximum dose of 60 milligrams per day. Okay, this should be for the first 6 weeks. Then for the next 6 weeks, you will give it like alternate day treatment. In alternate days, you will give it in a reduced dose. How much? 1.5 milligram per kg per day to a maximum of 40 milligram. This is what is the dose and schedule of steroid treatment in minimal change disease. Now, I was telling you, excellent response, right? How do you define this response? That is an important question for yourself. How do you define response? In simple words, it is decrease in proteinuria, right? But how do you define it very correctly? Protein in the urine becomes very, very less than 4 mg per meter square per hour, okay? Or in terms of dipstick, it is just nil or trace. Or in terms of PC ratio, how much it should be? Less than 0.2. If this is the findings, then you can say the child proteinuria has decreased or the child has responded to steroid. And in children, any nephrotic syndrome which responds to steroid is usually a minimal change disease. So that is why this condition, even without a biopsy also, you can diagnose based on this characteristic response to steroid that you could improve. So steroids are the mainstay of management in nephrotic syndrome. Is there any other thing which you can do? Yes, you can try diuretics, but only if edema is significant. This is something very important because the moment you start steroid and the proteinuria start decreasing, that itself will take care of the edema also. Edema will start automatically decreasing, right? However, diuretics only thing very important because the moment you start steroid and the proteinuria start decreasing, that itself will take care of the edema also. Edema will start automatically decreasing, right? However, diuretics only if edema is very significant, and which diuretic you can use, usually if required, furosemide. Along with that, the second diuretic, if there is no response to furosemide alone, you can add spironolactone also. Okay, right. So these are the drugs which are useful in the management of nephrotic syndrome. Okay. Now coming to the course of disease in minimal change disease. Remember, this is a condition which shows a tendency to occur again and again. Or in other words, 75 to 80% of the children will show relapse. Relapse means recurrence of proteinuria. That's it. Nothing but recurrence of proteinuria. So they tend to have repeat episodes. Okay. And every time the child is showing a relapse, we are going to manage with steroids only. And management of relapse is slightly different. What we have to do is we have to give daily steroids. The same dose 2 mg per kg per day till proteinuria resolves. To this, we have to give daily. Okay, and every time the child is showing a relapse, we are going. Manage with steroid. Or in other words, 75 to 80% of the children will show relapse. Relapse means recurrence of proteinuria. That's it. Nothing but recurrence of proteinuria. So they tend to have repeat episodes. Okay, and every time the child is showing a relapse, we are going to manage with steroids only. And management of relapse is slightly different. What we have to do is we have to give daily steroids. The same dose 2 mg per kg per day till proteinuria resolves. Okay, right. So daily steroid till proteinuria resolves. Then what we have to do is we have to give alternate day steroids. What is the dose for alternate day steroid? I already told you previously. What is that? 1.5 milligram per kg per day for 4 weeks. This is the management plan whenever the child is showing a relapse. Okay, so this is what we have to remember. Okay, now there are certain special situations which you should be knowing about. A few conditions and corresponding management I am going to tell. One is something called frequent relapse. Okay, that means very frequently child is showing episodes of proteinuria. And what is the definition of frequent relapse? These are all things which are given by guidelines and you should be knowing very correctly. What is the definition of frequent relapse? More than or equal to 2 relapse in 6 months, okay, or more than or equal to 3 relapses in 1 year, then it is called as frequent relapse. This requires some modification in the treatment. Why? Because frequent relapses, you are going to give frequently steroids. That can itself predispose to development of side effects of steroid or steroid toxicity can develop. So you have to manage slightly differently. I tell you the management short. Then there is one more condition also called steroid dependence. What's the meaning of steroid dependence? Very simple. Child's body is dependent on steroid. Meaning, if you stop steroid, child is again showing an episode of nephrotic syndrome. And by definition, steroid dependence refers to more than or equal to 2 relapses while the child is on alternate day steroids, or within 14 days, very important, within 14 days of stopping steroids, then it is called as steroid dependence. So you can understand one thing very clear. What is that? Child's body behaves as if it is dependent on steroids to achieve remission. Okay, right? So here also, if you continue to give steroid, child will remain in remission only. But can I do that? If I use steroid for a long period of time, again steroid toxicity is going to happen. So in both frequent relapses and steroid dependence, I will not continue giving the usual dose of steroid because steroid toxicity will develop. So in both these situations, I have to give some other form of immunomodulatory medication. Any idea what are we using for management of frequent relapse or steroid dependences? In India, the number 1 drug for this is levamisole. Number 2 drug is mycophenolate. This is what we are using for management of frequent relapses and steroid dependence. Then there is one more special situation called steroid-resistant nephrotic syndrome. Very simple. The name is explanatory that the child is not responding to steroid treatment. Okay. And steroid-resistant nephrotic syndrome is usually not due to minimal changes. Very important. What is the point about minimal changes? As I told you, it responds to steroid. So when I have steroid-resistant nephrotic syndrome, I have to think it not due to minimal changes. Very explanatory that the child is not responding to steroid treatments. Then there is one more special situation called steroid-resistant nephrotic syndrome. Very simple. The name is explanatory that the child is not responding to steroid treatment. Okay. And steroid-resistant nephrotic syndrome is usually not due to minimal changes. Very important. What is the point about minimal changes? As I told you, it responds to steroid. So when I have steroid-resistant nephrotic syndrome, I have to think it is usually due to a significant glomerular lesion. It is usually due to significant glomerular lesion. Okay. I have already told you what is the examples of significant glomerular lesion. Something like FSGS. That would be the pathology causing nephrotic syndrome in a child with steroid-resistant nephrotic syndrome. Or it could be due to congenital nephrotic syndrome. Very important. It could be due to congenital nephrotic syndrome. Congenital nephrotic syndrome, by definition, refers to a nephrotic syndrome where the onset is before 3 months of age. So can you see that it is a very early onset of nephrotic syndrome? That is also usually a steroid-resistant variety. Okay, right. So what the point to be noted is, it is not usually due to minimal changes. That is why. So suppose I have a child refers to congenital, something like FSGS. That would be the pathology causing nephrotic syndrome in a child with steroid-resistant nephrotic syndrome. Or it could be due to congenital nephrotic syndrome. Very important. It could be due to congenital nephrotic syndrome. Congenital nephrotic syndrome, by definition, refers to a nephrotic syndrome where the onset is before 3 months of age. So can you see that it is a very early onset of nephrotic syndrome? That is also usually a steroid-resistant variety. Okay, right. So what the point to be noted is, it is not usually due to minimal changes. That is what. So suppose I have a child who is having steroid-resistant nephrotic syndrome. What will I do? Of course, I am not going to use steroid, I am going to use some other drug. But before that, I have to establish the diagnosis, correct? So for that purpose, what should I do? I do first renal biopsy. Very important. Because here I have to establish what is the pathology, right? Previously, steroid-sensitive nephrotic syndrome or responding to nephrotic syndrome is only minimal changes. I don't even need to do a biopsy. But here, I am confused. It could be due to many conditions. So renal biopsy should be done, number 1. Number 2, if needed, I will do the genetic testing also. Genetic testing is usually for congenital nephrotic syndrome cases. So if I have a child who is less than 3 months and presenting nephrotic syndrome, I will also do the genetic testing to look for some gene mutation. What are the gene mutations? I am going to tell you shortly. As of now, just remember, genetic testing is a part of evaluation. Steroid-resistant nephrotic syndrome for a very small child. Third thing I have to do is glomerular filtration rate estimation, GFR estimation, because it is generally noted in steroid-resistant nephrotic syndrome, the kidney functions tends to become decreased or abnormal. So that is why GFR estimation also should be done. So these are the first few things I am going to do. Then, of course, I have to start the treatment. So which drug do you think is going to be useful in the management? Mission also should be done. The far estimation, because evaluation, steroid nephrotic, steroid resistant nephrotic syndrome for a very small child. Third thing I have to do is glomerular filtration rate estimation, GFR estimation, because it is generally noted in steroid resistant nephrotic syndrome, the kidney functions tends to become decreased or abnormal. So that is why GFR estimation also should be done. So this is the first few things I'm going to do. Then, of course, I have to start the treatment. So which drug do you think is going to be useful in the management? It is another class of immunomodulatory medications. Can you tell me the name? What is the drug for steroid resistant nephrotic syndrome? It belongs to the group of, yes, calcineurin inhibitors. Calcineurin inhibitors. I have given you the clue. You can tell me the answer. Which drug is it? Yes, it can be cyclosporin. One more answer. Quickly think and try to tell the answer. Yes, tacrolimus. These are the group of medications for management of steroid resistant nephrotic syndrome. Are you able to follow this? Okay, right. Now I was telling you for congenital nephrotic syndrome, we have to do genetic testing. What is the meaning of congenital nephrotic syndrome? Onset before 3 months of age. Okay. Now the only question for exam is what are all the different genes which can become abnormal in case of congenital nephrotic syndrome? Okay. Number 1 is a gene called NPHS1 gene, which codes for a protein called Nephrotic. For management of steroid resistant nephrotic syndrome. Are you able to follow this? Okay, right. Now I was telling you for congenital nephrotic syndrome, we have to do genetic testing. What is the meaning of congenital nephrotic syndrome? Onset before 3 months of age. Okay. Now the only question for exam is what are all the different genes which can become abnormal in case of congenital nephrotic syndrome? Okay. Number 1 is a gene called NPHS1 gene, which codes for a protein called nephrin, and it can undergo gene mutation resulting in congenital nephrotic syndrome. This is what we call Finnish type nephrotic syndrome. Finnish type nephrotic syndrome, which is inherited as an autosomal recessive mode of inheritance. This is number 1. Another gene is also implicated called MPHS2 gene. This also has autosomal recessive mode of inheritance only, and that gene codes for another protein called odosin, the damage to which can also result in nephrotic syndrome. Number 2. Number 3 is one more gene which is implicated in the causation of a condition called Denny-Drash syndrome. Any guesses on what is that gene? WT1 gene. And this condition is inherited as autosomal dominant mode of inheritance, very important, AD, autosomal dominant mode of inheritance. And in Denny-Drash syndrome, there is an increased risk of Wilms tumor. Increased risk of Wilms tumor. You can easily understand from the gene name itself, WT, Wilms tumor, like that you can remember. Number 2 point in Denny-Drash syndrome is it is usually associated with ambiguous genitalia in a male child. These are the additional features. Okay, right. So you can see that in congenital nephrotic syndrome, your questions are going to be based on what is the gene defect. So make sure you know it very, very thoroughly. Okay. So these are like special situations in nephrotic syndrome. I told you. What are the things I have told you there?
Ambiguous genitalia.
One would be frequently relapsing nephrotic syndrome. Second would be steroid dependent nephrotic syndrome. Third is steroid resistant nephrotic syndrome. In that one group is congenital nephrotic syndrome. These are all like special situations in nephrotic syndrome. But if I ask you the question, what is the usual condition causing nephrotic syndrome in a child? It is always minimal chain disease only. And how do you identify minimal chain disease? It shows a striking or an excellent response to steroids. That is what should be your summary points for nephrotic syndrome. Okay. Now, just one more thing is complications in nephrotic syndrome. Okay. Some complications can be present and that has to be managed also. First would be infections. Okay. And these children are prone for many type of infections like SBP. What is that? Spontaneous bacterial peritonitis. Spontaneous bacterial peritonitis. They can also develop cellulitis. They can also develop pneumonia. And what is the reason why they are developing infections? Any idea? Spontaneous managed also. 3 points for nephrotic syndrome. Okay. Now, just one more thing is complications in nephrotic syndrome. Okay. Some complications can be present and that has to be managed also. First would be infections. Okay. And these children are prone for many type of infections like SBP. What is that? Spontaneous bacterial peritonitis. Spontaneous bacterial peritonitis. They can also develop cellulitis. They can also develop pneumonia. And what is the reason why they are developing infections? Any idea? See, there is proteinuria, correct? And as a part of proteinuria, there is loss of Ig. What is that? Immunoglobulins, which are also proteins, are getting lost in the urine. So the immunoglobulin level decreases or the immunity level decreases. Not only that, the complement proteins can also be lost in the urine. So there's a complement deficiency also occurring in this particular condition. And because of this reason, the problem is that it will result in impaired opsonization. Very important, impaired opsonization. So now, I'm going to ask you one more question. When opsonization gets impaired, what type of
complement proteins?
of infections are going to be common in these children? Yes, what type of infection? I'm going to ask you one more question. When opsonization gets impaired, what type of infections are going to be common in these children? Yes, what type of infection? Of course, bacterial infection only. Which type of bacterial infection? Yes, encapsulated bacterial infections are common. Encapsulated bacterial infections are common. Okay, can you tell me some examples of encapsulated bacteria? One name and bit right here. Yes, Streptococcus. Yes, completed. What is that? Streptococcus pneumoniae. Correct. Streptococcus pneumoniae. That I'm writing it. That's a commonly encountered organism. Any other organism? Haemophilus influenza type B is also coming in. That's bacterial infection. If opsonization gets impaired, what type of infections are going to be common in these children? Yes, what type of infection? Of course, bacterial infection only. Which type of bacterial infection? Yes, encapsulated bacterial infections are common. Encapsulated bacterial infections are common. Okay, can you tell me some examples of encapsulated bacteria? One name and bit right here. Yes, Streptococcus. Yes, completed. What is that? Streptococcus pneumoniae. Correct. Streptococcus pneumoniae. That I'm writing it. That's a commonly encountered organism. Any other organism? Haemophilus influenza type B is also coming under encapsulated bacteria that can also cause infection in these children. Okay, so this is one complication which you can expect in these children. Okay, then one more set of complication is hypercoagulability of the blood leading to thrombosis. Leading to thrombosis. And that thrombosis can be associated with infarctions of the organ, like for example, CNS infarction, it can result in stroke manifestation. All those problems can be encountered. But why hypercoagulability of thrombosis? Very, very simple reason is there is loss of anticoagulant proteins. What is that? Protein C as well as protein S. They are lost in the urine. Because of the anticoagulant proteins are getting lost, there can be increased chance of coagulation or clots. Number one. Number two, there is an increased production of a procoagulant protein or a protein favoring coagulation. What is that? Fibrinogen. And this happens at the level of the liver itself. Hepatic production of fibrinogens increase. That also predisposes to the development of thrombosis or hypercoagulability. So these are some of the complications encountered in case of nephrotic syndrome. Now let us quickly finish off the nephrotic syndrome topic with the summary box. Okay, you are going to tell me answers in between. What is the hallmark feature of nephrotic syndrome? I'm talking about investigation. What is that? It is massive proteinuria. Along with that, clinical feature would be generalized edema or NSRK. Simple. Which is the overall most common cause? It is MCD only, minimal chain disease, usually in young children, and it shows good steroid responsiveness. Very, very important point. Next thing, relapses are a common occurrence. I told you 75 to 80% of the children with minimal chain disease will have relapses, and they are also managed with steroids only. However, if it is a frequently relapsing nephrotic syndrome or steroid dependent nephrotic syndrome or steroid resistance, you have to use other immunomodulatory medication. Quickly recollect, for frequent relapses and steroid dependency, what is the medication? Levamisole or mycophenolate. That's what we are using. For steroid resistance, what is the drug we are going to use? Calcineurin inhibitors like cyclosporin or tacrolimus. Okay, so that is about the summary points in case of nephrotic syndromes. Next, moving on to nephritic syndromes or